Hello everyone. Today I'll be speaking about abdomen imaging, specifically abdominal x-ray. So let's look at the PowerPoint right here. Okay. So the points that we are going to cover for today are abdomen x-ray definition. So what is an abdominal x-ray? Second is image acquisition. So how is the x-ray acquired? That includes patient position, part position, central ray, things that have to do with technique. Third is radiographic technique. Four is regions and quadrants. Five, is image evaluation criteria. We have contrast medium and acute abdominal series. Okay, so let's move on. Number one, abdomen x-ray definition. So what's an abdominal x-ray? An abdominal x-ray is an x-ray radiograph of the region of the abdomen. The region of the abdomen is that region that lies between the thoracic region and the pelvic region. So between the chest and the pelvis. As we can see in both images right here. On your right hand, we have a plain x-ray of the abdomen. Labeled, and on the left hand we have also an x-ray of the abdomen, but it's not plain. It's a special procedure called a barium enema, where we induce radio opaque material to the patient, and we acquire x-rays that look just like this. So I have actually magnified images. Alright, so here they are. So this is the barium enema actually. So you can look at the large bowel right here. You can look at the basic anatomy of the large bowel through this image. We have the ascending colon right here, following the cursor. We have the hepatic flexure. The hepatic flexure is the curve or the flexure that occurs just below the hepatic region or the liver. This is the liver right here, so the hepatic flexure is here. Then we have the transverse colon. This is the transverse. And then we have another flexure here called the splenic flexure. So this flexure is pertaining to the spleen, from its name splenic, so the spleen lies in this region. And then we have the descending colon right here, the descending as in coming down, and then it forms the sigmoid colon. You can see the nice S shape right here forming the sigmoid colon. And then we have the rectum, the distal most part of the bowel. So this is the barium enema image, and then we will have a look at the basic abdomen x-ray. So alright, we will start with the basic anatomy of an abdominal x-ray. Number one, we will start proximally, moving on distally. Proximally as in the part above and then going to the part below. So number one, we have major organs in the abdomen. Those are also viewed in the abdominal x-ray. So number one, we'll start with the liver here. Alright, so we can see the liver right here. You can follow my cursor. You can see the tip right here. This is the shadow of the liver following all the way up. So this is the liver region right here. Alright, we have another major organ, that's the kidney. The kidney is now considered to be an organ from the urinary system that lies within the abdomen. So this is the distal part of the proximal part of the urinary system lies in the abdomen, and it has to be visualized in the abdominal x-ray. We only see the shadow of the kidney. If we have proper penetration, we can see the outline of the shadow. You can see it right here. It's very clear. And then we have here, this is the kidney shadow. So this is the right kidney, and then we have the other kidney right here. This is the left kidney. You can see the shadow right here. So we all know that The right kidney is lower than the left kidney because of the position of the liver. So normally you can see here the base of the right kidney is lower than that, a little lower than that of the left kidney. Alright, so we come to the hepatic flexure that we just spoke about. So this is the ascending colon. How do we know this is the ascending colon anatomically? You can see here some gas bubbles. Yeah, this is gas within the large bowel, and then the gray shadow is fecal matter that is filling the large bowel. So this is exactly how we know anatomically that this is the ascending colon. It's part of the large bowel. Alright, what else? So the psoas muscle. The psoas muscle is a really important part in the abdomen x-ray. Why? Because it forms a landmark to search for other organs, especially the kidneys. Now, if you don't find the kidneys for any reason, there's a lot of gas, the patient is obese, let's say there's an ectopic kidney, or for any reason that you cannot find the kidney, you try to locate your psoas muscle. The psoas muscle is right here. You can see this line right here, the hyperdensity here. There is a line formed at both sides. We have the left side and the right side right here. It inserts right here. It's actually called, this is the psoas part of the iliopsoas muscle. The iliopsoas muscle extends all the way down. This is the iliac part, and this is the psoas part, forming the large iliopsoas muscle. But the psoas muscle only starts from here and extends all the way right here. Okay, so this is the psoas muscle. As I said, it's an important landmark to locating the kidney. We have the lumbar vertebra. It's very helpful in counting the lumbar vertebra when we have a proper abdomen x-ray. So we can landmark the rib. So this is the floating rib, the 12th rib. You can see it's a floating rib. So if this is the floating rib, then this is considered T12. Then we start counting for the lumbar vertebra. This is L1, 2, 3, 4, 5. You can see right here, this is the 5th lumbar vertebra. The 5th lumbar vertebra is very distinct, and it's very important. Why? Because when a technologist tries to do the abdomen x-ray, we actually locate the iliac crest right here. It's actually palpable if the patient is really thin. Even in heavy patients, it's palpable, but in thin patients, it's really prominent. When they lie supine and all that, the abdomen it comes down, we can actually locate or palpate the iliac crest. So this is the iliac crest right here. It's part of the bony region. The crest is right here, and the wing is right here. This is the iliac wing. Okay, so this is part of the bony region. Coming down, we can see these are the sacroiliac joint. We have the left and right SIJ, sacroiliac joints. They are nice and visible. Then we have the sacral bone right here. And we have the tailbone or the coccyx. The coccyx are not usually very clear because of the bladder shadow, or because of the bowel gas, because of so many things going on there. You cannot visualize the coccyx, very easily, but you can see it right here. We can see both hips. We have the left hip joint, the right hip joint, and the distal most part is the symphysis pubis. We should not cut the symphysis pubis. This is abdomen x-ray, or in radiology we have another term for it. It's called KUB, kidney ureter bladder, because you can visualize the kidney, the ureters coming down, and then the bladder. It's very sufficient when you want to image the urinary system. Check for a kidney stone, a ureteric stone, or a bladder calculi. Then you can request for a KUB. This is exactly why they call this a KUB, because you can visualize these three structures. Okay, and then we have the spleen up here. You can only see the shadow. Alright, so what's so special about the abdomen x-ray and about the organs of the abdomen x-ray is that in radiology we actually look at subject contrast. Subject contrast is a synonym to the organ density. Now, an example is a chest x-ray. When we look at a chest x-ray, let me retrieve a chest x-ray to make it easier. So yeah, here. When we look at a chest x-ray, you can see the air-filled cavities. This is black, and then the bone is white. So this is high subject contrast. You can differentiate between black and white. But in case of the abdomen, it's really different. You have here low subject contrast. Why is that? Because the kidney has nearly the same density as the liver, the same density as the spleen. So it will be very difficult to actually look at the detail of each organ, but you can see the outline or just the shadow because it has a low subject contrast. This is the case of the abdomen. So the abdomen should include patient name. If not name, it has to include the patient hospital number, and it has to be correctly labeled. This is the right side here. This is taken from Wiki Radiography. This is the right side, so this is the left side. It has to be correctly labeled for reporting. If we have a stone in the right kidney, then the right side has to be labeled properly. Mistakes can happen. If you have a right kidney stone, you take the patient to lithotripsy and the doctor wants to let's say perform a procedure on the right side. They may end up performing a procedure on the left side, causing damage to the healthy kidney. It's quite of a risky business, so double checking is usually a good thing. Alright, so this is pretty much with the abdomen anatomy. Alright, so this is an abdomen x-ray AP, anterior posterior view. It was obtained with the patient I'm not sure if it's standing or supine, but most probably supine because of the gas pattern. When you have a standing chest x-ray or an erect chest x-ray, you usually see the gas going upward in an upward direction. But since here we have the gas dissipated all over, it's most probably a supine abdomen x-ray. So let's speak about image acquisition. In image acquisition, we usually have the position of the x-ray tube and the patient position. The most famous acquisition position in abdomen x-ray is the supine and erect. Erect, where the patient is standing and the central ray, the CR of the x-ray beam, is coming perpendicular to the cassette right here. And in the supine, the patient is lying supine on his back on an x-ray table. So here we see the standard AP supine and upright abdominal patient position. Okay. So other positions, these are actually special positions. This is the patient is also supine, but you can realize the cassette is lying at the side. Okay, this is a special position. We will see later when is it indicated. And the position to the right also is a special position. It's called the lateral decubitus. Since the patient is lying on the left side, we call it left lateral decubitus. And you can realize here the cassette or the bucky is at the back of the patient. Okay. Yeah, there's something really special here about the abdomen. Since we divide the lung to lobes and zones, we divide the abdomen into regions or quadrants. So let's speak about the quadrants. Quad means 4. That means the abdomen is divided into 4 quadrants. We have the RUQ or the right upper quadrant, left upper quadrant, left lower quadrant, and right lower quadrant. Now, each quadrant is special clinically. Why? When the patient marks out pain, let's say in the left upper quadrant, you will know what you're looking for. Then the pain is probably coming from the stomach or the left lobe of the liver, or let's say the spleen, or the portions of some of the small and large bowel. So it's really clinically important to actually identify the quadrants of the abdomen, to identify where is the pain likely coming from. So here the right upper quadrant includes the right lobe of the liver, gallbladder, the right kidney, and portions of the small and large intestine. The right lower quadrant here, it's composed of the cecum, the appendix, portions of the small and large bowel, and reproductive organs. This is very important. The right ovary in the female, and the right spermatocord in the male, and the right ureter. Now, sometimes clinicians, when they examine the patient will be suffering pain in the right lower quadrant. So the physician here has to identify, is the pain coming from an abdominal organ or a pelvic organ? Because if it's an abdominal organ, then he may or she may request an abdomen x-ray. And if it's coming from a pelvic organ, an ultrasound would be more helpful. Alright, let's go to the left lower quadrant. We have the most of the small intestine. Now, I was asked the question that day, how can I differentiate the large bowel from the small bowel in an abdomen x-ray? It was a very good question, and this is one of the answers. Most of the small intestine is situated in the left lower quadrant. You will not find a small intestine, let's say, at the splenic flexure of the large bowel. So anatomically, you can identify which is the small bowel and which is the large bowel most of the time. Okay, so it has the left ureter, the reproductive organs, the left ovary in a female, and the left spermatocord in a male. So these are the four quadrants. And then we have the regions. Regions are actually divided into 9 regions. And they have names also to identify organs. We have the right hypochondriac, epigastric. Epigastric means just right at the stomach area, the epigastrium. We have the left hypochondriac. We have the right lumbar, the umbilical. Here we see the umbilicus in the middle. We have the left lumbar, left inguinal, hypogastric. Hypogastric is just below the gastric region, and we have the right inguinal. These are the 9 regions. So you can divide them according to regions or quadrants. Similarly, in an abdomen x-ray, it helps in looking at the organ according to the quadrant or the region. It will make it easier to locate anatomically. Right, we went through the anatomy. Alright, so we have the bony structures within the abdomen. So let me just minimize and go back to the abdomen x-ray anatomy, and we will... Alright, sorry. Okay, so the bony framework of the abdomen. Number 1, we have the costal cartilages. Or let's not say the costal cartilages. It's actually there, but what we see more prominently in the abdomen x-ray are the distal part of the ribs. Let's call them the floating ribs. We have the 11th and the 12th rib. We have the iliac crest, as I located earlier, right here. We have the anterior superior iliac spine and the anterior inferior iliac spine, and the superior pubic ramus, the pubic arch, the pectineal line. We will talk about lines and measurements when we talk about the pelvis x-ray, but the pelvic region, all the pelvis is included within the abdomen x-ray. Why is that? Because it contains the distal portion of the bowel, and the distal portion of the bowel is very crucial to us also. So here we said we have the SIJs, we have the anterior superior iliac spine, and the anterior inferior iliac spine. We will come to those in a later time. Okay, we have the ischial spine, we have the iliac crest, the xiphoid process in the body of the sternum. Now we cannot see the xiphoid in the body of the sternum here because it's not included. We will see them in another radiograph. Okay, we have the pubic symphysis here, the superior pubic ramus and inferior pubic ramus right here, here and here. Okay, this is the hip joint and the acetabulum right here. Okay. So again, anatomy. This is a very specific image. Why did I include this? Is to actually include the special anatomy within the urinary system. Since the abdomen x-ray does not only include the digestive system, it also includes the urinary system. This is a very special procedure, including the abdomen x-ray. It's called IVP previously. It stands for intravenous pylography, or IVU, which stands for intravenous urography. Now, the purpose of this image is to highlight the urinary system or any pathology within the urinary system. Now here you can see this is the left kidney, you have the right kidney, you have the right ureter, you have the left ureter, and you have the bladder. The dense area is contrast medium. It's intravenous contrast medium. You can see distension right here. It's very clear. Okay, this is actually the anatomy of the urinary system within the abdomen. Okay, sorry. Alright, yes, we have barium studies also. We will speak about barium, but a barium study includes inducing barium to the body either orally or rectally to highlight the digestive system structures. So this is a barium enema where barium is induced rectally. We can see here the barium. It's very dense. We call it radio-opaque. It has a very high density, and you can see the folds here in the large bowel. They are called hastrations. This is one distinct feature of the large bowel anatomically, which are the hastrations. So in that way you can easily locate the large bowel through that. You can see the black shadow here. This is negative contrast. So we have, I said that the barium is radio-opaque. So what is against radio-opaque is radiolucent. Radio-opaque indicates high density, radiolucent indicates low density. Radiolucent is usually pertaining to bowel gas. Whether it was induced through external means, sometimes we induce a negative contrast or radiolucent contrast to actually highlight the bowel even more. You can induce it via a mechanical method. There is a device for that. Or you can induce it by giving the patient soda. That will induce bowel gas. We do that in radiology department. It's a very special procedure. So this is positive and negative contrast. And here you can see the stomach. It's nicely highlighted. You can see the fundus here. It's full of gas. And some of the rugae here is highlighted with contrast, since the patient has probably been moving. The image is quite probably in the oblique position, from the position of the spine, a little bit oblique. You can see the spinous process here, indicating an oblique view of the stomach during a barium meal. You can see this is the stomach here. Okay. Alright, now this is another special procedure done within the radiology department, incorporating the use of oral contrast. It's called the small bowel series, and we use it to highlight the whole region of the small bowel. So what we do is that we give the patient oral contrast to drink, and then we will start taking images on specific times. So let's say we take an image after half an hour, we take after 1 hour, 2.5 hours, or 2 hours, like that, just to follow the contrast moving in the small bowel. You can see here the anatomy, very nice. The duodenum right here. This is the first part of the small bowel as it comes out from the stomach, you will find the duodenum. See, when we talked about the regions and quadrants, they said there was a part of the small bowel is here. Right? We have the convent valves. Then, this is not very significant, but then we have the jejunum and the ileum. These are the three parts. The jejunum here, it has a very special appearance, and it lies in the left lower quadrant mostly, and a little bit of it in the left upper quadrant. This is the jejunum, and then you have the ileum. And then the ileum connects with the large bowel at this region right here through the ileocecal valve to the cecum. But in a small bowel series, we usually try to take images at intervals not to include the large bowel, since it's called a small bowel series. Alright, so let's speak about types of contrast in the digestive system. Usually, how do we induce contrast with digestive system? It's through oral means. Oral or rectal means. So, oral contrast. Number one, we have barium sulfate. This is an image of barium sulfate flavored with berry, since it has a really sharp and unfavorable by patient taste. Barium sulfate is a compound used as an X-ray contrast medium. We use it in both X-ray and CT scan that occurs in nature as a mineral barite. So the mineral barite is available in nature, then it's made to become medically available as oral contrast. It is also used in various manufacturing applications and mixed into heavy concrete to serve as a radiation shield. So one would say, wow, how can something like that be induced into the body? Now we should know that anything that comes through oral means is passes through the bowels, and then through the process of defecation is eliminated from the body. So it does not go anywhere. None of it is absorbed within the body. None of it is absorbed through the system. So this is why we consider it safe. So barium sulfate is quite insoluble in water. So if you see barium sulfate on reality, if you open the bottle and try to touch it, it's really heavy. It has small granules or particles. So it's considered insoluble in water and is used as a radio-opaque agent to diagnose gastrointestinal medical conditions. Barium sulfate is taken by mouth or given rectally. Do not administer barium sulfate via IV. Contraindicated, very dangerous, and it's not even an option. That's why barium sulfate should be administered by a trained staff within the radiology system. Okay, names. These are the names of the contrast. We have barite, baritop, barium sulfate, micropaque oral, or barium sulfate. So this is the chemical composition. It's said here, although barium is a heavy metal and its water-soluble compounds are often highly toxic, the low solubility of barium sulfate protects the patient from absorbing harmful amounts of the metal. Since it does not dissolve in water, we do not worry about the body or the bowel absorbing it inside the body. It will pass through the digestive system safely. So indications of barium sulfate contrast medium, we need it to opacify the GI tract, to separate intraluminal structures from extraluminal abscess. This is very important. So let's say the patient has been sent from the clinician for a barium enema, or let's say whatever barium sulfate examination, and the patient has an abscess, an abdominal abscess. Now, I talked before about density and subject contrast within the abdomen. Now, assuming there's an abscess in the abdomen and we take an x-ray, we cannot see it because the abscess will have the same density as the tissue inside the abdomen. So this is quite a disadvantage. I mean, the patient will go non-diagnosed. So what we do here, when an abscess is suspected to be inside the abdomen and the clinician wants to rule out the presence of an abscess, or let's see the location of the abscess, we need to give the patient oral contrast. Once the oral contrast highlights the bowel, then we can see the abscess position in relation to the bowel, because the bowel now is highlighted, and we also give IV contrast, but that's a whole other topic. And then to detect GI tract tumors. So contraindications, this is a very important slide because barium sulfate introduction to the body can have extremely harmful and lethal effects. So patients who have difficulty swallowing and are likely to aspirate. I'm going to show you an image right now. Where is it? Let's see, right here. So this is a patient that underwent an oral contrast examination of barium and got aspirated within the chest. This is a very dangerous case actually, when barium, which is a heavy toxic metal, is aspired within the respiratory system. You can see right here down the trachea and the contrast going in the main bronchus. This is the right main bronchus and traveling down. So this is one image, and this is the second image. See, it went through the bronchial tree, forming a phenomena or a radiographic appearance called air bronchogram. So this is it's a very dangerous thing once the patient aspires barium sulfate. So if the patient, let's say inpatients that have NG tubes, NGT, nasogastric tubes, and actually have difficulty swallowing or cannot swallow at all, and all the materials and foods are administered through the nasogastric tube, it's it's quite contraindicated in that case. We have patients are at greater risk of an adverse reaction to barium sulfate contrast materials if, let's say the patient has cystic fibrosis, which will increase the risk of blockage in the small bowel. Very common contraindication. Patient is severely dehydrated, which may cause severe constipation. We said that the barium sulfate has heavy particles, and eliminating the amount of barium from the body can be difficult for some patients, causing constipation. So if the patient is severely dehydrated, we do not advise it. We need to hydrate the patient first, assess the risks and versus benefits of the exam, and then we can administer barium sulfate. And the most important, the last but not least, patient has an intestinal blockage or perforation that could made worse by a barium sulfate agent. I would only imagine a patient with a perforation swallowing barium sulfate. If in that case barium sulfate manages to leak from the intestine to the surrounding space and to the body, it can literally cause systemic failure, and the patient can die if not managed. If managed, then it's okay. Honestly, I haven't seen cases in the radiology department where the patient has taken barium sulfate when having perforation, but it can be very bad. It can be a death case. And an intestinal blockage. So if the patient has a blockage, then you wouldn't ask for an oral contrast examination. His intestines are already blocked. Alright, so that means for clinicians, do not send your patient to have a barium scan or an oral contrast examination if you are suspecting perforation. If the patient just had a surgery within the digestive system, a very recent surgery, sometimes the area of surgery is not ligated properly and the barium can leak. So these are contraindications where the clinician does not send the patient to have a barium scan. Alright, now we have something called omnipaque or low osmolarity contrast medium. It's an ideal CT contrast medium, also for X-ray, not just CT, for abdominal exam. It is relatively non-absorbable and of low risk to patient if aspirated. This is an alternative for barium sulfate as an oral contrast if the patient has the contraindications we mentioned above. Let's say the patient is suspecting, we are suspecting a perforation and we want to check the site of perforation. Now, this is an indication for contrast, but not barium. Omnipaque or Omnipaque, which is a low osmolarity contrast medium. It's water soluble, it's absorbed by the body if it leaked, and of low viscosity, which permits uniform distribution. The advantages, it's poorly absorbed from the normal GIT. So if it passes through the GIT, it will opacify it nicely without actually absorbing it to the external of the body. Rapidly dissipated from the lungs if aspirated. This is the most important thing. If the patient aspired to low osmolarity contrast medium or Omnipaque, it can be rapidly dissipated. And it does not cause a frequent GI distress like constipation or severe constipation. Okay, so these are the images I just showed you. This is called accidental contrast aspiration resulted in air bronchogram on a barium swallow. Alright, so let's talk about the acute abdominal series. This is a very crucial exam when it comes to abdomen x-rays. I mean, a high percentage of abdomen x-rays are requested in a form of acute abdominal series, or abbreviated as AAS. So what is an acute abdominal series? What is it composed of, and why is it requested? So the acute abdominal series determines the amount of bowel gas with possible bowel distension, assess air fluid levels, query pneumoperitoneum. If we have a perforated ulcer, then we would look for free subdiaphragmatic air, but it has a poor sensitivity sometimes to small bowel obstruction. So this is the first image, but let's look at it closely. It's right here. Alright, so this is an abdomen x-ray. It's nicely marked. So this is the right side, and it's in the erect or standing position. So how do we know this is in the standing position? Number one, it's marked. Number two, look at the gas pattern. So normally when the patient stands, there is gravitational force pulling us down. But there are some low density or very light structures that go against the gravitational force, and one of them is air, especially air inside the body. We can see here we have air in the lungs, we have air in the stomach is situated right here, and we have air in the bowel. Okay, so these are the positions of air we have when we look at an abdomen erect in the acute abdominal series. Air, as we said, since it goes against the gravitational force, it will go upwards. See here, air is going up. Right here, air is going up while fluid is left down. You see here, air fluid levels. See the lines here. Line. There's a line here, quite a line here, line here. There are many lines. These lines separate the density of the air with the density of the fluid. Here we have high subject contrast. We have a very light structure, that's the fluid, and we have a very dark structure, that's the air. This is a characteristic of air fluid level that indicates bowel obstruction. Okay, so this is what an acute abdominal series erect radiograph should look like. The evaluation criteria of the image, it needs to include at least the lower 1/3 of the chest. Right here, you need to detect subdiaphragmatic air. or for query pneumoperitoneum, the technologist that acquires the image has to and must include the diaphragm area. If it was not included, then the physician has the right to send the patient back to the department to get it, because you cannot diagnose for subdiaphragmatic air if you do not have the diaphragm. You cannot rule out pneumoperitoneum if you do not have the diaphragm. You need to include both the lateral walls to include the whole abdominal region, and you need to include the pelvic region if possible. Here, part of it is cut because the range of the film or the cassette does not allow to image the whole area. So it's quite okay if the lower region is cut. It's okay. So here we can confirm clearly there's bowel obstruction by looking at air fluid levels. So this is the first radiograph. This is the standing. All right, so So what is the acute abdominal series composed of? It's composed of 3 radiographs, 2 minimum, 3. In some hospitals they use a protocol of 3, which is a chest PA. We have an abdomen erect PA, and we have a supine abdomen AP. These are the 3 radiographs that must be included in the acute abdominal series to consider it a full study. So that's the first image. Now the second image. Okay, let's look at it better. Right here, yeah. Okay, so this is the supine from the same patient, I suppose. I took this image from Radiopedia. So this is the supine abdomen x-ray. Look at now, the air fluid levels are not there anymore. You see? You can see the folds, the convolutions of the bowel. You can see the gas, you can see some fecal matter, but you cannot see the air fluid level. Alright? Because in the supine position, things change. The gravitational force now is acting on the back, and it will let air escape upward towards the belly or towards the frontal part of the abdomen rather than the upper part of the abdomen. So air will rather dissipate than actually rise or accumulate superiorly. You can see here distinctly in the evaluation criteria, the diaphragm is not included anymore. Why? Because air will not be found under the diaphragm due to the gravitational force and the movement of the air, as we said, in a supine position. But the pelvic region here is all included. Okay? So this is a successful technique to acquire abdomen images in the acute abdominal series. This is labeled well. This is the right side, and in the supine position. The position also has to be labeled. Okay, so let's identify some anatomy here. There's the spine. It's centered. We see the patient has some deviation of the spine. This can be due to 2 reasons. Now, this is a very good critique within the image. Now, usually lateral deviation of the spine is diagnosed as scoliosis, but in the cases of bowel obstruction, the patients are really in pain. This amount of gas pressing against their abdomen and their backs, it causes excruciating pain sometimes, and the patient cannot really lie down easily. So it can be a positioning error, and it can be some scoliotic changes. This is not of significance right now, but it's just a point to ponder. Okay, now this is a very nice question here now. Is this the large bowel or the small bowel? We will come to that in other images, and then we will come to answer this. Okay, so this is, alright, the chest x-ray. This is the chest PA. Okay, let's look at it. Oops, sorry. Let's look at it closely. Right here. Okay. So look at this chest x-ray, a nice chest x-ray, PA, posterior anterior, looking at the size of the heart. It looks like it's a PA chest x-ray. There is no significant enlargement of the heart. The appearance of the clavicle also is a good indicator. And then we have the gas. See, the subdiaphragmatic gas has rised up against the gravitational force. That's most likely indicates that the patient was in the erect or standing position. Look at the massive amount of gas under the diaphragm. Now, how do you diagnose subdiaphragmatic air? You look at the hyperdense line right here. This is the muscle of the diaphragm. The muscle here becomes so clear because of the distinct density change between the air and the diaphragmatic muscle. So you have here air that has escaped from the abdomen and went all the way up to reside under the diaphragm right here. And I guess this case is a perforated ulcer, perforated stomach ulcer that caused air to escape under the diaphragm. Alright, let's do an evaluation criteria of the chest. It's a nice PA chest x-ray. Okay, you can see here the heart, central, the exposure factors are really nice. You see here the upper portion of the abdomen isn't really clear. You know why? Because the exposure factors technically are set to give you a chest x-ray so that you can highlight the black areas of the lung and the white areas of the bone so that you can see the air under the diaphragm. It has no diagnostic significance in terms of looking at the abdomen. The second and third images should be acquired in that case. So, in summary, in acute abdominal series, we have a minimum of 2 images. That's the supine AP abdomen. Next, we have the upright or standing or erect PA abdomen. PA is done for radiation or for radiation protection purposes and a technical consideration also, because a PA, that means the patient's belly or the patient's abdomen is the part closer to the machine or the bucky or the cassette. I will show you somewhere if I have it. Yeah, right here. These are different positions when acquiring an abdomen x-ray. Not all of them are abdomen. Some of them are lumbar spine, but let's see the abdomen ones. Right here, you can see the back of the patient coming on the bucky, but this is not what I meant actually. Let me see if I have another one. This is also an AP since the x-ray is coming from the front part and exiting the back part. Okay, it seems that I don't have that position. Okay, so anyways, when you acquire a PA, that places the abdominal organs closer to the detector. This will increase the resolution and of the image and the quality of the image. This is actually a technical consideration. Okay, this is a very interesting radiograph. You can see it has a strange position. It's oriented in a strange way. This radiograph is acquired with the patient in this position. Alright, this is called a lateral decubitus. What's the significance of a lateral decubitus? It's actually very significant and very important in checking the amount of air. Okay? Look at the patient position now. The gravitational force is acting right here, down to the floor. That means the air will escape upward right here. Now looking at the image that we just saw, look at the air. The air is up here. Now this is not marked properly because there should be an arrow coming downward saying this part down. But you can really tell from the anatomic orientation of the organs. You can see the fluid coming down, precipitating towards the gravity, and you can see air going upwards. So this is also an indication of bowel obstruction. This is small bowel obstruction. Alright, so this answers our question of the previous radiograph that we said we'll go back later. It was actually a small bowel obstruction. We will know now how do we differentiate small bowel from large bowel. Okay, this is called SBO, small bowel obstruction, AAS, acute abdominal series. This is the string of pearls sign. We all know how a pearl necklace or a string of pearls look like. It will look something like this, you see? It's like beads that are interrupted at a certain point that form a string pattern. This is a sign on a radiograph indicating small bowel obstruction. Okay, so this is the report of the previous image. It said dilated loops of bowel. You can see how massive the small bowel has become. I mean, knowing the gross anatomy of the small bowel, you would not believe that this is actually the small bowel. This is why you can mix up very easily between the large bowel and the small bowel. So this, we said dilated loops of bowel with air fluid level. We said here, these lines, fine lines, indicate the air fluid level right here. It's very clear. Right here also. Levels compatible with the small bowel obstruction. We said the string of pearls sign is present in the lower abdomen. The lower abdomen. We said, right, this is the lower abdomen right here. Since it's in a strange orientation, maybe something that is not compatible to your eye, you would say, okay, where is the lower abdomen? The lower abdomen is this region right here, and you can find it here. Okay? This is a case. I actually took it from a journal. The title is Imaging Patients with Acute Abdominal Pain. So the arrows easily indicate fluid level, air fluid level. Now, is this a large bowel or a small bowel? You should confidently say this is small bowel obstruction. Why? Because of the orientation. Remember when we talked about quadrants and regions, there were specific areas where you had the small bowel mostly situated here. There's some of it up here and here. You can see the dilated loops actually, and the formation and the shape of the loops. So let's read the description. I attached this literally word by word from the journal. So it says an upright conventional abdominal radiograph. Okay, upright. What does that mean? That means the patient was probably standing or sitting, but it's highly likely to be standing. So it's an upright conventional abdominal radiograph obtained in a 59-year-old man who had abdominal pain and a distended abdomen. So these are the clear signs and symptoms and the clinical presentations we find on our radiology requests. When the technologist comes to do the radiograph, we will look at patients suffering abdominal pain. On clinical examination, there's the distended abdomen, okay? As well as history of SBO 3 years ago. So this is probably a reoccurrence. Alright, for which he was treated conservatively. So they followed the conservative treatment to conservative treatment to eliminate this SBO. Shows distended small bowel loops and air fluid levels consistent with SBO. The previous obstruction was most likely caused by adhesions because the patient had previously undergone appendectomy. This patient was again treated conservatively. I will make a lecture again about types of bowel obstructions. There are many types. So clinical history is extremely important. You cannot rely only on the appearance of the radiograph. When you have a clear clinical history for the patient, you would actually see the report coming. You would somewhat predict what's gonna appear on the abdomen x-ray. So yeah. This is back to the case. You can see the appearance of the small bowel loops. Okay? So this is the end of part 1 abdomen imaging. Thank you very much for watching. I will actually come to explain a couple of images that I have downloaded just to let you know the differences between the large bowel and the small bowel on an abdomen x-ray. So first of all, we spoke about the anatomical location. Now we need to speak about the radiographic appearance. Okay, so radiographically, you need to look for the shape of the loop. Here we have what I said previously called haustration. Follow my cursor, you can see it like this. See? These are called haustrations. This is a distinct characteristic of the large bowel. So this is actually one of the characteristics in terms of shape, and this is how you differentiate it shape-wise. Second is the anatomical location. So in terms of anatomical location, let's see. Okay, let's see this one. I mean, we cannot see it very closely here, but the large bowel, let's look at this anatomy. The large bowel takes something called a circumferential pattern. So it ascends, it transverses, not in a straight manner like here. Yeah, here. This is clear. It ascends, it curves, it transverses like this, not in a straight pattern like we see in anatomy books. It actually takes a bit of a shape. It again curves and then it descends. So this is a significant pattern when it comes to the large bowel. Alright, then you have the haustrations, as I said, and in the large bowel and also the small bowel, the wall pattern can be hugely affected by distension. Okay, these are nice haustrations. Again, this is gas and this is contrast. Alright, so this is when we come to the large bowel. Now coming to the small bowel, let's see here. Alright, when we come to the small bowel, number one, location-wise, it doesn't cause, it does not curve around the body just like the large bowel. It's situated in the central abdomen. You will not find small bowel in areas where it's not supposed to be found, unless there's a pathology like distension that's going to cause it to displace itself. But anatomically, it's in the central abdomen. And also the wall pattern can be affected by distension, and it has a special wall pattern. It's unlike the haustrations. You can see it right here. It's unlike the haustrations seen in the large bowel. Okay, now coming to another thing. Let's see, I'm not quite sure I actually snapshot the values. Okay, unfortunately, I wasn't able to snapshot them, but I will explain here under the radiograph. Alright, now when a radiologist or a radiology doctor measures the bowel to actually indicate if there's bowel obstruction or not, there are specific values. We have the 3-6-9 rule. Okay, remember that 3-6-9 rule. It's very useful to guide you in determining whether these bowel loops are normally dilated, like it's just gas within the bowel, or it's abnormally dilated to the extent that you have to diagnose it as a bowel obstruction. So the 3-6-9 rule indicates the small bowel the maximum normal diameter for the small bowel should be 30 millimeters. That is 3 centimeters. So when you come to measure the small bowel, let's say this, it will not, the normal size, it will not go beyond 3 millimeters. Okay? When it comes to the large bowel, it's 50 to 60 millimeters. That's 5 to 6, 50 to 60 millimeters. That's 5 to 6 centimeters. Sorry, mind my math. Okay. So when you come to measure the large bowel, for instance, you do not go beyond the designated values of 50 to 60 millimeters. So if you take a measuring tool on the radiology monitor, you will measure, look at my cursor, you will measure like this. Let's say, for instance, for example, since this is not the optimum image for measurement, but we will measure like this. We will take the maximum diameter. Okay, the maximum diameter obtained on the radiograph, and this should not go beyond 5 to 6 centimeters or 50 to 60 millimeters in the large bowel. Coming to the cecum, it shouldn't go beyond 90 millimeters, that's 90 centimeters. The cecum, here, this is the cecum. Yeah, the cecum is indicated as the first part of the large bowel. It joins with the small bowel at the ileum, forming the ileocecal valve. Okay? Okay, I guess that's about it. Thank you so much for listening. I hope it was with benefit, and hope to see you again in other videos. I will make a part 2, so wait for it. Thank you very much.